We're grateful that you can be here for this technical briefing on day 2 of the World Health Assembly, where we're going to look at the application of emerging technologies to public health and also to clinical practice. I'm James Chow, the WHO Goodwill Ambassador for SDGs and Health. And there's an opportunity here in the first ever Chief Scientist position, which was created by the Director General earlier this year, who appointed Dr. Samia Swaminathan. And before starting her job here at WHO, we all know that Dr. Samia was Director General of the Indian Council of Medical Research. She was also the Deputy Director General. Dr. Tedros also, in that mold, created a new central research for the Health Department within the Science Division. So what we're going to do here in this time together is a little different to the other briefings you may be enjoying at this assembly, as it's to start a discourse about how WHO can better anticipate relatively early stage technologies for their impacts on medical health, public health, clinical practice, and also health systems. And what WHO wants to do, so that we ensure that this is an interactive space today, is to seek your input as they begin a rather new scope of work. And of course, we hope that you find it engaging, dynamic, and interactive. We also want to look at this renewed commitment that WHO has brought forward in terms of not only impacting health, but also how governments are going to make the decisions to expand access, and how we can bridge the ethics in science, how we can introduce the legal perspectives and also the social impact, because of course you've got to bring it back to the people. So we have 3 world-leading speakers who are going to touch on 3 important critical areas where we feel that emerging technologies may enjoy dramatic impacts on public health and clinical practice in the years ahead. We're going to have Dr. Chikwe Ikweazu, who's the CEO of Nigeria's Center for Disease Control, and he'll talk about major outbreaks of infectious diseases that Nigeria's had to negotiate, and how pathogen sequencing technologies are providing critical information to help guide the public health response. We're also going to have Dame Anne Johnson, who is the Vice President of the UK Academy of Medical Sciences, who's going to explore its own work on considering implications of emerging AI technologies for health systems, both in the UK but also globally. And we'll start off with Professor WHA72 on the WHO Advisory Group on Governance and the oversight of human genome editing, and this as an example of science with ethical, social, and legal perspectives. And that's going to be followed by a panel discussion, and perhaps if there is time, we're going to seek the interventions from you as well. Let's start off with Dr. Swaminathan, who's going to share a few words to give us insight on how she's going to oversee, but also provide direction to this work in emerging technologies as part of those new responsibilities of the science division that she leads.
Thank you very much, James, for that very nice introduction and setting the scene. And good morning to everyone, and thanks for being here early in the morning. As you know, the Science Division has been created after 70 years of WHO's existence, even though everything WHO does has been based on science and evidence ever since the beginning. So it's been widely welcomed, I think, by the global community, because especially in the age we live in, it's really important for us to keep underlining the importance of evidence, of truth, and of really bringing forward the issues that are important for public health and which otherwise may be neglected or get sometimes caught up in politics. So I'm really honored to lead this division, and we have 3 new departments under this: the Quality Assurance of Norms and Standards, a Research for Health department, and a Department of Digital Health. All of these, of course, are closely interlinked, but they're all going to be cross-cutting functions that are going to work across the different departments of WHO, the technical departments, but also across the different levels, the regional offices and the country offices, because everything we do ultimately has to have an impact in the countries. So in the GPW 13, we actually have some quite visionary sentences and paragraphs in there which talk about reinforcing WHO's science-based normative work, impact, and anticipate and assess the impact of research and discovery on public health. It also says that all of WHO's policies and public health interventions and research will be grounded in ethics and that we will develop ethical guidance in emerging health fields. And we're going to hear from Professor Schneeweiss a little later one example of the work that one of the WHO committees is doing. We're also going to be engaging with academics, with partners, with other agencies that are involved in emerging technologies. And this will really require a dialogue because technologies are emerging at a fast pace, their applications are emerging at a fast pace, and we need to be able to assess, as I said, the public health benefits versus the anticipated risks that could occur. So there's always a possibility of dual use and dual use research. So one of the functions of the foresight unit that we will set up is really to look at what technologies are emerging and to have debates on, to start dialogues with civil society, sociologists, economists, lawyers, etc., to look not only at the biomedical applications or implications, but at all the other repercussions. So I think it's really important, and we want to strengthen our global health ethics unit so that we go beyond just research ethics, but really start addressing some of the big issues like artificial intelligence, facial recognition, the use of big data, machine learning. What implications do these have? But it's also very important to keep in mind that data sharing more and more is going to be an important issue for us to discuss. We believe that health data is a global public good and that there are enormous advantages to having some sort of data sharing agreement or code of conduct or principles agreed to by countries. And I'm talking about demographic data and so on, anonymized, but also data on pathogens, especially on pathogen sequences, which, if shared, could provide enormous advances in knowledge, because then you have a global community of researchers who are able to work on that. This will require, of course, further dialogue and discussion, and we plan to invite, we plan to have many of those in the coming months. So we really want to hear from all of you what you think the main challenges are, what you think the opportunities are, what the science division could focus on. We do have limited time today, so we will now, I think, proceed with our presentations, but hopefully some time for a little bit of discussion. Thank you very much.
Thank you very much to Dr. Salmia. So we're going to jump right into the presentations that she just outlined for us over there. And as I said, we're going to begin with Professor Hervé Schneeweiss, who sits on the WHO Advisory Group on Governance and oversees the human genome editing. He is currently the head of the research center at the Neuroscience Paris Seine, and he's also head of the INSERM Ethics Committee. He has exercised his expertise over many years on bioethics of human embryos, human genetics, and also neurosciences. Professor, we hand over to you.
For the invitation, and as it was just said, my real job is to be a neurologist and the head of a neuroscience research center, but as you can see, I'm involved in several ethics committees, and I'm particularly happy that I was invited to this expert group of WHO that I will present the work now. So what is genome editing? I am going to jump to the very last technique named CRISPR-Cas9, but it's also already a very long story, 20 years. It's making some change, targeted modification of the genome. And to do so, with the last technique, you need at least two components. One, which is a nuclease, which is going to cut the DNA. The other one, which is a guide, and in this case, CRISPR, which is going to target this nuclease to a precise place of the genome. And this now, we can do it with CRISPR-Cas9 easily, fast, and very efficiently for a very low cost. But after the cut, we require, or we request the cell to make the DNA reparation itself. And at this stage, we are not controlling anything more. Generally, what is happening is that there is the recruitment of a DNA repair mechanism named NHEG, which is efficient, rapid, but absolutely not viable. It's going to remove or to add a few bases. Imagine a text, a word text, where you erase 1 or 2 letters, or if you add 1 or 2 letters, but you let the whole text the same. So you are going to have a frame shift, and the text is no more possible to read. It's exactly the same for genes. You are going to invalidate the expression of the gene. But you are not going to control if you add or remove 1, 2, 10 base pair. The second mechanism is less effective if you want to replace by a new sequence. For example, to correct a mutation, you need to bring a template, and in this case, it's much more difficult. So you see that immediately we are going to have several problems. Obviously, it's a wonderful technique which is going to be a real revolution, and it's not in the future. The revolution is now. It was already done by old techniques of genome editing, named zinc fingers or TALEN. It already raised nice results. For example, the invalidation of CCR5 could really cure patients with HIV. We already had the recovery of a child with an incurable acute lymphoid leukemia. Several trials are ongoing, and within this year, 2019, you will see dozens or hundreds of patients saved thanks to these new technologies. It will be in the field of cancer first. It will be in the field of rare disease. For example, sickle cell disease or beta thalassemia will be on the list for clinical trials this year. But all these technologies that are on somatic cells, they are ex vivo. You take the cells from the patients, you change with a targeted mutation, you select the correct cells, you amplify the correct cells where the correct modification has been done, and then you reinject to the patients the corrected cells. Because you have millions of these cells, you can select the ones that are correctly modified. Obviously, we have problems of cost, we have problems of technologies, but you have also to remind that in this case, we only modify somatic cells, so there will be no irritability of the change. So now, what is possible by editing the germline? You have two possibilities. One is to change somatic cell, and then you reprogram through the system of induced pluripotent stem cell, and you differentiate the cell in spermatogonia or in eggs. This is something that has been done already for animals, mice, rats, even for macaque, but not in human, but it could be. The second strategy could be to modify directly the zygote, but the zygote is only one cell. It was what happened in China with Jiang Wei. And as you've seen, the problem is that with this one cell, you have a single shot, and what was done was not genome editing, it was mutation, it was wrong about the science, it was wrong about the medicine, it was wrong about the ethics, and it's clear that it's not possible to go there today because you cannot select correctly the cells. So in this framework, WHO and its general director required a group of experts to oversee the needs for governance in the field. And this group is multidisciplinary. I have no time to go into the details, but you can go on the website of WHO. You will see on my last slide and see all the details of this advisory group. The Director General and Ms. Swaminathan requested us to review all the existing initiatives and literature, to make recommendations, to link with other initiatives, including academies, including new association, and to see what could be the best governance in this field of genome editing. We already met once in Geneva in March, and the committee already made 3 recommendations, and they are implemented now. The first one is to establish a registry, because science needs transparency, and we need to know who is doing what. And this registry will now try to oversee what kind of research are ongoing that could lead to some change in human genome at large, but especially on heritable human genome, meaning on the germline. The second recommendation was a clear statement. It should be irresponsible at that time to make any kind of genome editing on the germline. And it's clear that we will need stewardship to oversee the research that has been done and to see in which scientific, technical, and ethical condition at one day it might be possible to use these techniques, maybe to cure some devastating rare heritable disease. The third recommendation was to not only oversee, but liaise all our initiative with the other initiative, and to make the WHO to engage its various branches to be able to bring the information to the general public, all layers of the public, the lay public, the expert, in the different eras, and bringing it with the natural language understandable by the various population. If you want to engage the public, you need to bring the information and to bring it on a way understandable by the larger audience. So the work has already started. Several groups are working. We are going to continue and to make the work scalable at the various levels from the lab to the international development. And finally, it will clear that we will do that in a scale of 1 or 1.5 years. Next meeting in August. Developments you will see on the website. And I thank you for your attention. You can find additional information on the website of WHO and more particularly the one of the committee. If you want to have some more information on the scientific information or on the initiatives that has been already taken, you can also go on the website of ARIGE, Association for Responsible Research and Innovation in Genome Editing, where you will find scientific text and also opinions that were published by various learned bodies. Thank you for your attention.
Thank you very much to Professor Hervé Schneeweiss for sharing some of your new findings. And as you said, it's not in the future. The revolution in technology is right now. We're going to link that now to Professor Dame Anne Johnson, who is Professor of Infectious Disease Epidemiology and also Chair of the Population and Lifelong Health Domain at the University College London. She's also here as Vice President of the UK Academy of Medical Sciences, and she's known for her depth of work on the epidemiology of HIV infection and other infectious diseases. As we said earlier, she's going to talk about the work of the Academy, considering implications of emerging AI technologies for health systems in the UK and also globally. So we can now welcome Professor Dame Anne Johnson.
Well, good morning, everybody, and thank you very much for the invitation to speak today. I'm going to talk about artificial intelligence and its role in transforming healthcare systems. And as I think many of you are aware, we are in the process now of seeing the emergence of a range of digital technologies and artificial intelligence that could frankly transform the delivery of healthcare, health systems and public health. But to do so requires a great deal of preparation in terms of infrastructure and training. And perhaps most of all, we need to make sure that the technologies that we use are tested against clinical ground truth and mitigate the risks in relation to ethics and aspects already referred to, such as data security. Now, artificial intelligence, AI, is only part of the range of activities which could be described as digital health. This slide comes from a review undertaken in the UK called the Topple Review, led by Eric Topple, looking at the training requirements for us to move into a digital environment for health in the UK. And of course, part of those technologies are the emergence of genomics, the emergence of AI and robotics, alongside ways of communicating, for example, through remote consultations in health, which could really transform delivery of health systems to remote communities and really change aspects of organizational development. Now, many of the new technologies were reviewed in the Topple Review in the UK. Here they are, and the key developments in AI are those marked there in red. Now, artificial intelligence involves a large degree of machine learning and so on, and it's all dependent on having underpinning it excellent clinical data for us to develop aspects of machine learning and use of speech recognition and so on. So the key technologies which were regarded as driving forward AI in health are speech recognition and natural language processing. The use of automated imaging, investigation using AI. So that, for example, is the reading of scans and X-rays automatically by machines rather than by individuals and specialists in the area. But of course, that in turn relies on having accurate diagnosis to test the machine learning against and really large-scale and reliable data. Thirdly, the development of interventional robotics. And lastly, predictive analytics, again based on clinical records that allow us to predict from people's clinical histories and from being able to look at millions of data points to be able to understand through machine learning the likely nature of people's diseases and to define optimal treatments and so on through machine learning. But you can see that the time scale of those shown in the arrows are, some of them are nearer than others. We're seeing much more development in telemedicine, but for many of these areas of AI, they are still currently in development. And the concern really is there's a great deal of hype and about AI and how it might transform things. But it's our job, I think, to ensure that we use these new technologies responsibly and effectively if we are to improve health services and public health. Now, a recent review was reported by USAID and the Rockefeller Foundation on artificial intelligence in global health. Now, that report identifies 4 areas where AI could be used to impact in low and middle income countries, and indeed in high-income countries as well. The first is AI-enabled population health, and this is an area that is of particular interest in the field of infectious diseases, for surveillance, for investigating outbreaks, and for epidemic prediction. The second area was that of a frontline health worker who might become, as it were, a virtual health assistant, and in this scenario, a healthcare worker who had some degree of training could have their work enabled by apps and other AI algorithms which would help them in making both a diagnosis and considering optimal treatment for someone in, for example, a rural or other remote settings linked into a healthcare system. The third, of course, is for the patient themselves. I'm sure many of you already will frequently use the web to consider your own care. I mean, there are now a great number of websites available where you can now access, as it were, the medical textbook for our own use. But you can imagine a system whereby people would have apps to seek expert advice on when and where to obtain self-care. And many people already are beginning to use apps to consider aspects of their health, measuring their own blood pressure or monitoring their blood sugar remotely, but at present these methods are not linked into health systems. And then finally, physicians themselves being able to use a range of AI in order to, for example, read images or to use algorithms in relation to machine learning and optimal management of care. And all these systems are beginning to be developed, but it's just the beginning. And if you think about many settings where we might want to institute AI, we really do need to have underpinning that the infrastructure essential for delivery, such as mobile phone networks. We need investments in digitized health communication. In many areas, we don't have the cloud computing, which is required to use these systems. Broadband coverage is a problem. And one of the real issues that is also being faced is whether, with the development of digital technologies, we create a digital divide. In other words, rather than making access better, we increase inequalities because we limit access to those who are least competent or least digitally literate, if you like, and who don't have access to the technologies which could improve their health. So there are many, many challenges in delivering what technological solutions are now being developed. So to give you a few examples of what is on the way, this is some work which I have been involved in the UK, and this is a review in Nature, looking at how we could take mobile health diagnostics in the infectious disease area into the field. And here the idea is that you could have a remote, point-of-care diagnostic test. The patient takes the sample. The result on an easily read diagnostic test could be read by their mobile phone, and some of these devices are being developed. That in turn could be fed into a cloud-based analysis. The patient then can be diagnosed in a remote setting, linked into the services of a healthcare worker to prescribe treatment or management. That in turn linked to a surveillance system, linked in turn to location, providing both a public health system, a clinical system, and management for the patient on the ground, linked in, of course, to data storage and retrieval. But that's easier said than done. That requires a great deal of technology, a lot of concerns about how one correctly manages all the data, as has already been mentioned. But these technologies are being developed. Here's a second application. This is a different piece of work, again, now being adopted by Public Health England, which is a means of using social media and search queries to try and track flu-like illness. So, as you know, it's quite often difficult to detect the first emergence of a new epidemic of flu, and basically people begin to search in relation to their illness early on, often before the health system can detect the flu-like illness. And doing that, we can detect the emergence of a flu epidemic about around 4 days earlier than the clinical systems can do so. Another area is that of automatic image interpretation, in this case for the detection of breast cancers using machine learning, which of course we use double reading, but the second reading can be done through machine learning, really reducing the number of skilled, trained individuals we need to carry out this work. But critical to this is the governance and making sure that it's clinically effective and is appropriately developed with CE marking in clinical trials. Here's another application in mental health here, a mental health bot, a triage bot being used for patients with mental health problems, and this bot is using voice recognition technologies to recognize not only patterns in the voice, but also, for example, suicidal ideation and so on, enabling people to be brought into care early, put into a system called IAPT, which is the early intervention pathway in general practice in the UK, and to have their mental health managed better. And you can imagine many countries where there are limited mental health service where this could be used. But this is all very well said in theory. In practice, there's a great deal that's required. We need infrastructure, collaboration, critically public engagement, involvement of the public, huge elements of training, because most of us are miles behind in imagining using these technologies. There's many questions about regulation and evaluation, interoperability, and cultural barriers, because many of these systems are being developed in one country, but they need to be rolled out in different languages, in different cultures, for different problems. And the business model is not yet clear of the relationship between development in the private sector and use in the public sector. We mustn't exacerbate inequalities. These technologies need to be developed for all areas of the world. And if the algorithms that make a diagnosis are faulty, who is liable, and how should regulation be developed? These systems rely on good clinical data, and data need to be both secure and private. There are big questions of governance and ownership of data. Many of these algorithms are being developed, or systems are being developed, but they need to be tested against clinical ground truth. And that requires a great deal of clinical trial identification and research to be carried out. And we need then to be able to say, as we do in other clinical trials, that this system of diagnosis is fit for purpose. And in preparing for implementation, a number of countries are now doing work. In the UK, we had our TOPL review looking at workforce and health service development, what is required to deliver these technologies in the health service. The Academy of Medical Sciences has developed a set of principles for data-driven technologies around governance and ethics. WHO, as you've heard, has its own global digital health strategy, considering a number of areas of engagement, measurement, and research. And I've shown you the USAID report. So that's a very brief skip through where we are. But in the end, I leave you with three conclusions. First, that AI could really transform healthcare. Secondly, that there's a great deal of preparatory work to do if we're going to get there. And finally, that we must ensure that if the AI we put in place is clinically effective, cost-effective, widely available, safe, ethical, and linked to a functioning healthcare system. Thank you for your attention.
Thank you very much to Professor Dayman Johnson for sharing, I think, a fascinating basket of new technologies that throws up a lot of questions, but also really opens us up into thinking how AI can transform opportunities for us all. We're going to jump into the panel now and take a deep dive into some of the issues that have been raised by our speakers. And for this panel, we're also bringing in Dr. Suri Moon, who is the Director of Research at the Global Health Center at the Graduate Institute in Geneva. Dr. Moon, thank you very much for being with us. Her research and teaching focus on global governance and health, including the governance of technological innovation and access to medicines. And some of her current projects focus on international sharing of outbreak-prone pathogens and related benefits, as well as new business models of pharmaceutical R&D. Before the Graduate Institute, she was a co-director of the Project on Innovation and Access to Technologies for Sustainable Development at the Harvard Kennedy School of Government. Dr. Moon, can we go to you first and look at one aspect of what we're hearing about? I think when we listen to all of this today, one of the questions that comes up is, what have we learned from access to medical and health products that can help guide WHO's work in ensuring timely access to emerging technologies, and, as we heard just now, in an equitable way, so that it is widely available, so that it is widely applied and benefited?
Great, thank you very much, James, for the introduction, and thanks for the invitation to be here. I think the previous speakers highlighted a number of the governance questions that already arise linked to some emerging technologies. What I'm going to do is focus on the global governance questions, because that's really my area of research. And as I was thinking about this panel, it occurred to me that what we think of today as emerging technologies will, of course, in the future no longer be emerging. And if we think back to the 70s, for example, with the development of the personal computer, to the 80s when antiretroviral treatment for HIV was an emerging technology, to the 1990s when the ability to prevent cancer with a vaccine could arguably be an emerging technology, to more recently when the ability to modify the avian flu virus to potentially make it more transmissible or more potent is also an emerging technology. These are, of course, questions that rapidly begin to raise a number of difficult global governance questions around who has access to these technologies, how do we minimize the harms, how do we maximize the benefits. I think oftentimes we tend to focus on the ethical questions, particularly when new technologies are developed. We don't quite know how to make sense of and think about technologies. But as technologies become a bit more mature, some of these other questions around access and the direction of innovation, I think, also arise. So in thinking particularly about what might be the role of WHO, where has WHO played an important role in the past in the area of technologies, I think there are 4 important functions that are particularly relevant to put on the table. They are selection, regulation, the direction of innovation, and access to innovation. So when we think about selection, WHO already plays a very important role, for example, in the development of the essential medicines list, the essential diagnostics list. It helps countries to decide what, in fact, are the most important technologies from a public health perspective. So it helps to select from a very broad range of technologies because, of course, not all technologies are of equal use, particularly when we're talking about trying to reach some of the poorest populations. When we think about regulation, WHO also already plays a very important role in helping to ensure the quality of products as products are produced. For example, the Good Manufacturing Practices Guidelines and many other guidelines, the work to strengthen regulatory authorities helps countries, again, to minimize harms and to maximize the benefits of new technologies. And I think in these 2 areas of selection and regulation, WHO's role is really quite well established and quite well understood. I think the 2 other areas WHO has definitely played a role, and I think will increasingly be called on to play more of a role in the future, and that's in the direction of innovation, which is, I think, perhaps an academic term, but this is really the question of what types of technologies, in fact, do get developed. And what role can WHO play in identifying or highlighting where technologies are missing? So where do we need more research and development? Where do we need science to focus some of its energies in order to meet public health needs? Where are those areas missing? Because we know the innovation system by itself may not necessarily always respond to the most important public health needs. This would also include, of course, adapting existing technologies. And I think in Professor Johnson's presentation on AI, we saw a number of questions raised. How can we adapt technologies that are primarily being developed in high-income settings at the moment to make sure that they, in fact, offer benefits on a broader basis? And of course, WHO has already played an important role in identifying priority pathogens of pandemic potential, for example, in identifying a top 10 list of infections, for which antimicrobial resistance is increasingly a concern and where we need new medicines. The last area that I mentioned is really access to innovation, and this is, of course, an issue that is always difficult. It's high on the agenda of the Health Assembly this year. It will continue to be a very important issue. And I think this is where WHO, again, has played a very important role. But it also faces many challenges, I think, because we're talking about not only scientific issues, but also issues of intellectual property, industrial policy, a number of private interests as well as public interests that come into the mix when we're trying to ensure that 7 billion people can get access to the most important and beneficial new technologies, and not only a minority of the world's population. But I do think this is an area where increasingly WHO will be called on to play a leadership and governance role. Let me just close my comments by highlighting that there are a number of governance questions that are primarily at the institutional level, in terms of research institutions, at the national level, but there are many that really require regional or multilateral governance. And I think it's on these questions that, again, the global community, as we've seen in the gene editing case, the global community immediately turns to WHO and looks for a place where information can be gathered, where input can be solicited from the global community, and ultimately advice can be given. How do we grapple with, understand, and again, best manage emerging technologies to minimize potential harms and maximize who can actually benefit from scientific advances?
Okay, thank you very much, Dr. Moon, for helping to build further on that stage. As we go now into this segment of the program, we're going to ask for some brief responses from our 4 panelists, because we've only got about 10 minutes to get this lightning round out of the way. And I know that we're dealing with very complex issues. So some brief responses to this. And I think, Professor Johnson, if I can just start off with you, you were talking about some of the potentially top performing apps. You were talking about the potential for the future of AI in health as well. I mean, given your background, one of the obvious questions would be in infectious diseases, and particularly in HIV infections. What have we learned from that? I mean, there were all these mobile phone technologies that were applied in low and middle-income countries in Africa, and particularly for AIDS. Is there any fundamental value lesson and technology lesson that we can take from that, and that gives you confidence that, you know, I think this is going to work. I think this is a way forward?
Just to give you an example of some work which is currently ongoing in South Africa. This is research funded by our Medical Research Council, where we've been looking at one of the big problems with HIV, as you know, is trying to get to the 90-90-90, that's 90% diagnosed, 90% on treatment, and 90% virus undetectable, is that we can, up to a point, get people tested, but it's very difficult to get people onto treatment, partly because the services are place-based, often far from where people live, and similarly, there is still a huge amount of stigma. So we've been just testing, still at the pilot stage, whether with diagnostics that people can use themselves, which are now self-testing is now available internationally. People have a self-test which they can carry out at home, but which they can then can be read by automatic reading and then read by the health system. The hope is that people might then be able to do the test themselves, then having got the result, be helped into care, and for that, the treatment, for example, to be delivered in the community rather than a place-based setting, trying to overcome some of the stigma, and then monitoring also done remotely. And you could see that that kind of system, whether it was for a stigmatized condition or not, could really change the way you deliver healthcare, because one of the biggest problems is people literally having to get to the place that they need to get treatment, and that a lot of the sort of management could be done without a face-to-face interview with an individual. What do you have to make sure, though, is that is safe? Now, one of the biggest learnings from this is the work we've been doing, talking to people about how they can, what kind of service is acceptable and is going to work for them. And it's a very complicated process. The technology itself does not solve the problem. It's all the other steps that link something into a healthcare system. But that kind of service could be transformative. Could also work for NCDs, the management of detection, management of hypertension, detection and management of diabetes. Many systems could be developed using these technologies because they allow you to do them remotely.
Dr. Swaminathan, you've now in this role been mandated to provide a scientific vision for the entire world. And we've seen, especially in the last couple of months, again in the news with the gene-edited babies, this mainstream concern around ethics and around responsibility and around values. I mean, where is WHO going to come in here so that your role provides science to the people and brings those benefits, but also brings it in a way that is compassionate, but also in a way that's going to bypass some of the harsh lessons we've learned with other technologies, like social media being one of them at the same time?
Thank you. Yes, I think there's enormous excitement, but also a lot of hype and perhaps expectations that are not really justified currently by the state of evidence we have now, and this was pointed out by many of our speakers. So what we want to do is to really be ahead of the curve a little bit, and the way we can do that is by engaging with the scientists and the science academies around the world to anticipate what is coming down the road that will be available in a couple of years, and also to start anticipating some of the challenges that were nicely outlined by our speakers. I think one thing that really strikes me is the fact that there's very little evidence really currently around using these technologies, whether it's mobile apps or whether it's AI-based algorithms for diagnostics, especially how it would work in a low-income setting. And I was at a dinner event yesterday with the Commonwealth ministers were talking about digital technologies, and one of the ministers was saying that the change management of the health workforce is probably more important than introducing the technology, because if you don't have a workforce that's able to deal with this and to be able to respond, there's no point introducing something. The health system also has to be able to respond. So I think one thing that I would like to do with partners is to really develop a research agenda around the use of digital tools, particularly to deliver primary health care. I mean, there's an opportunity here to leapfrog and to move in low-income countries into really delivering high-quality care using these tools. But this needs to be tested, and we need an evidence base before WHO can make guidelines.
Professor Geneva, I mean, you brought up a lot of fascinating facets of what is not only ahead, but you rightly said it's here, it's now, it's present. One of them being the somatic gene therapy in human beings using genome editing. If you could pick one aspect, what do you think is going to be, because you produce a whole basket of ideas, what would you say is going to be potentially the most transformative technology that you see ahead, which is appropriate for the current settings that you think WHO can help guide on, and you think is also going to, most importantly, bring the health benefits to potentially millions or billions of people?
Well, it's clear, as it was said, that we have to clearly see what are the priorities, because it's not because a technique is the most recent one that you have to forget all the previous techniques. And for example, if you take HIV, why it was medically wrong to do what WHA did, it's because you have other ways to prevent HIV infection, including direct prevention or use of some treatments. So you always have to remind about the minimization of the healthcare systems and the minimization of intervention on the body, which is a primary ethical aspect. What also we have to do is to inform and educate, because for example, there is a kind of magic which is associated with the genome, but the genome has nothing magic. If you take one generation to the other, we have between 40 to 80 new mutations, de novo mutations, that are naturally occurring, and it's 40 when the parents are young, it's 80 when the parents are older, and particularly when the man is older. And the genome is dynamic, so there is no magic to preserve the genome as an incredible, magic, natural entity. But we have to take care of our intervention to see what are the real benefit of such intervention, what are the real harms, and one of the work that is ahead of us for the expert group will have to engage with the academies to describe the assessment mechanisms to evaluate really the technology. So one of the things that real governance has to do is to set the scene as it really is, without too much hype, without too much fear, but with the real data and the real a priority for the benefit of the people, for the benefit not only of a few, but for the benefit of the real global health of the people. And if you take the needs like cancer, which are the first devastating disease all over the world, where you take the needs for the rare disease that are rare each case, but when you take the 7,000 types of rare disease, there are many all over the world. You have to tackle these real needs and to face the fact that these new technologies could bring us really at a new step of what kind of health we can provide to our citizens.
Thank you very much, Professor. I just want to finish off with a question over here, and perhaps we can think of this as speaking to one another. So perhaps Dr. Moon and Professor Johnson can parry a little bit very, very briefly, because we've got to go into one last presentation over here. I mean, there was this fascinating look into non-communicable diseases, leapfrogging process, for example, by using automatic image interpretation in terms of breast cancer screening, which was the case study that you provided, but also in a way leapfrogging stigma and discrimination through the mental health triage bot. Being able to detect human emotions before perhaps even we ourselves realize the emotions that we are going through. I mean, if you could just talk very briefly to each other and then to Dr. Swaminathan about where you see WHO bringing to life the technologies that you're all innovating and helping to guide. And then we'll just finish with that quickly and then push on to the next. So you both want to?
Well, to WHO, I think the points that are being raised, these technologies have to be tested in clinical practice and at scale. And that process of getting them into place to be useful really requires a lot of very hard work, just as we've done for this needs the work that we do for every drug we use, every medication we use goes through clinical trials. Similarly, these technologies need to be tested and rolled out, and the workforce need to be trained, so the principles are the same. So I would very much welcome the opportunity that WHO might have, both in thinking through how such a program might take place internationally, and secondly, what the funding model would be. Because one of the biggest challenges here, as I mentioned, these are being largely developed by tech companies. The model is very different. We tend to be in the public sector not rapid adopters, risk averse. On the other hand, that's not a bad thing either. So marrying those two things and thinking about how the funding model might work is really important, and the ethics are critical too. But I would really like to hear what you would say about many of the aspects about, for example, a bot that's listening to you. What are the privacy aspects of that? How do you protect people?
I'm afraid I'm not an expert on privacy, but I would just highlight that I think one of the key areas of comparative advantage that WHO can offer to member states is the ability to look across countries. Of course, countries will know best what are the health issues that they face, what are the challenges within their own health systems. But oftentimes, multiple countries face the same difficulties, whether it's a disease or a weakness in the health system, and to be able to build, in some sense, economies of scale and to say, at a regional or global level, these are needs that are not being met, that multiple countries face. How can we bring this to the attention of, for example, those with the technological know-how to, in fact, help to address some of them? I think the other is that we know that the knowledge and the understanding of a number of these technologies and the expertise barrier is very high, and that there are not so many people in the world who can fully grasp what is happening and to keep track of this. And so, again, for WHO to be able to pull together the best experts in the world, no matter which countries they come from, and to get the best scientific knowledge to help inform and advise both WHO and governments, I think that's, again, a very critical comparative advantage that no other institution has.
Thank you very much to Dr. Moon, and I know that Dr. Swaminathan is going to be absorbing everything that you're saying today and taking that forward. She really is in this new and exciting exciting first stage of her new role over here. We are going to wrap up, and we are very short on time, but we were waiting, and we're delighted now to be joined by Dr. Chikwe Ikweazu, who is the CEO of Nigeria CDC. He's now going to be speaking about the major outbreaks of infectious disease based on the experiences of Nigeria, what it's had to deal with, and how pathogen sequencing technologies are providing critical information on helping to guide the public health response. He is an infectious disease epidemiologist and has more than 20 years of experience working in senior public health and leadership positions. He's held several engagements for WHO, mainly in response to major infectious disease outbreaks around the world. Dr. Ikweazu?
Sprint over from the Intercontinental from somewhere else. I think someone has left his glass on the podium. But this is really just to share some experience of our work in the last couple of years with partners in Nigeria around sequencing. A few words about the Nigeria Center for Disease Control. It's a fairly new parastatal, modeled largely after the US CDC, but with a slightly narrower mandate, so only on communicable diseases, has a similar mandate like most other national public health institutes around surveillance, reference, laboratory services, outbreak response, etc. Now, having said that, obviously the opportunities that we have grown over the last few years, but so have our challenges. So literally since 2016, like most people in this room will know, we've been faced with, just at the end of July 2016, 2 months away from declaring polio eliminated in Nigeria, we had a new case of wild polio virus and started the whole cycle again. We're now, again, towards the end. We had a large meningitis outbreak, continue to have large outbreaks of Lassa fever. And, the reemergence of, quote unquote, the reemergence of monkeypox after close to 35 years. But you'll see why I've put the quote unquote and why it relates to sequencing and the opportunity that we now have with science to dig into these a little bit more. So this is just an incident trend of Lassa fever in Nigeria over the past few years. You can see the very similar trend. So we almost stopped calling them outbreaks, but just getting into the emergency phase of Lassa fever in Nigeria, knowing exactly when it will peak again. And obviously, we've had a lot of questions. What is going on? What are you doing? Is it a new virus? Is it a new strain? And all of that. And those are questions we've been faced with from both the scientific community and our political leadership. So we've started using sequencing very much as part of the outbreak response to try and understand what is going on and use that information to influence the work that we're doing. So this is data from 2018 when we established the national EOC. That's the first arrow, and by week 10 we had our the first results from sequencing done that showed that there were no new virus lineages detected. The virus is circulating, despite having a much larger outbreak than we've ever had before, were similar to the viruses that had been circulating before in the previous year. So it did look like actually the outbreaks were a little bit self-inflicted. As we had improved our surveillance system, we were suddenly detecting more viruses, and in effect, nothing much had changed. We also could demonstrate that the most likely cause for most cases were spillover events from rodents to humans. So again, that influenced how we managed the outbreak, because a lot of what we did for Lassa was very much influenced by the Ebola response, where you had a very intensive contact tracing exercise, very human resource intensive, following each contact for 21 days. And these results enabled us to really change tact a little bit and focus a lot more on rodent control and education, risk communication to try to prevent transmission from animals to humans. And so the same thing has continued this year. And then we found, and the virus, we continue to find new cases of Lassa across a wider geographical area in Nigeria. This year we found 5 new cases in a state called Kebbi that never seen a case of Lassa. Of course, it became a big issue, and very quickly we could use sequencing to demonstrate there was no new lineage of the virus involved. But I guess the most intriguing story about the utility of sequencing was when, in 2017, we saw a case, a really scary case that turned out to be monkeypox. I mean, I had never seen any case, any patient like this in my medical career in Nigeria, and very few others had. And, if anyone has seen a case of monkeypox, and it will quickly remember the days of smallpox in terms of how it looked, and really caused a lot of anxiety in the population. So we quickly, working with our colleagues in USCDC who did the initial sequencing for us, could demonstrate again that the viruses circulating in Nigeria most likely have been circulating for many years, had gone undetected. For some reason, there are more cases now, but found cases across the country that were not linked to each other, so they were not sufficiently similar. So the small cluster there were the only viruses that were sufficiently similar to belong to a single cluster. The rest were fairly different. So again, at least we could explain to Nigerians what was going on, and really we have continued seeing cases of monkeypox since then, and that has led to a whole new effort in terms of research to define what is going on in monkeypox, its epidemiology, its virology, and potentially the importance of new vaccines, both for monkeypox and other pox viruses. So to conclude, sequencing has really opened up a whole new frontier for us as a Center for Disease Control, an area that, to be honest, we're still building up our capacity on. Some new technology like the MinION sequencer has helped access to sequencing locally. The whole bioinformatics needs are still not easily accessible locally, so we still have a lot of work to do in terms of building capacity, working with partners. The opportunity has provided us insights to explain to the public what is going on around some of the major diseases in Nigeria, and really guided the outbreak response within the outbreak, and really empowered ourselves as leaders of this institute to provide explanations and then drive research. And out of both the Lassa and monkeypox responses have grown areas of intensified research now going on both diseases to further understand. So it's moved from just influencing the outbreak itself to influencing and building knowledge to understand the disease further in order to guide not just outbreak response, but long-term strategies. So, like you can imagine, none of this is possible within a small new parastatal like us, so we've had to really collaborate with academic colleagues both in Nigeria and beyond, sister national public health institutes. BNI is the Bernhard Nocht Institute of Tropical Medicine in Hamburg, but really come together with others, both to learn, to transfer technology, to build on the knowledge, and then to drive policy and knowledge in public health. So I thought I'll keep it short. Again, my apologies for coming late, and I hope there might be some conversations around this, even if it's outside the hall, since we'll probably run out of time. But thank you very much.
Thank you very much to Dr. Chikwe. We know that we said that this panel would finish, this briefing would finish at 9 o'clock, but we also appreciate that you came here for this, particularly early in the morning. So Dr. Samia welcomes any comments on the floor. It could be an idea, it could be a question, it can be a solution. If you just indicate that you'd like to speak, and then we can cross over to you. Yes, we'll go to the lady first and over here.
I think, in the question of artificial intelligence, what you would need to do, you can't develop so many different apps and systems that don't talk to each other. So all this should be put in the context of developing an infrastructure for e-health and m-health. So how do you see this progressing together?
Okay, I don't know if we'll get a response to that, but I think it's very, very good that we raise that now. And then we'll go to the delegate over there, please. Yes, to you. If you just turn on your microphone. Yeah.
Thank you for the presentation. The question also relates to investment question about AI. I would like to ask the panelists, if you have $1 to invest in the space, where would you put it? Is it the enabling environment, things like infrastructure data, or is it testing, clinical setting, what it is?
Then we are going to the gentleman there, then we'll go here, then we'll go to the back, please.
Actually, that was my comment or question. I will put it in enabling the environment, if you would like me to answer that question. And my point is, my name is Haitham Al-Nosh, I'm with the Norwegian delegation, and I work for the Norwegian Development Agency. I've been working on digital health for some time now, and have been following that since to talk about the importance of evidence, right? And now we have moved a long way where countries are picking up on this, and they are investing more and more in digital health systems. And the more they invest, the more need will be for technical assistance and funding, right? But the real potential is when we manage to enable the environment, when we manage to address the ecosystem elements that are crucial for these high-tech solutions to be able to give us good results. That's why Prof. Ann, I appreciate the point you mentioned on infrastructure, on enabling the environment for this. And again, the real potential for digitalization, for digital health, is not moving from paperwork to digital work. It's from using this technology to think in a new way, to shift the thinking, to develop a health system that is based on digital tools, not moving from paperwork to digital stuff.
Then we can finish off with the last two, this gentleman here, then there was a delegate, I think, over there.
Thank you very much. Definitely in the next 5 years, it's going to be a different world as far as AI and technology is concerned. But to a large extent, innovation and technology is driven by commercial interests and financial considerations. So what kind of practical role do you see WHO playing in terms of stewardship and ensuring equitable access to these technologies, especially in poorly resourced settings?
Please.
It's really a follow-on question very much to that. In addition to all the potential gains of AI, how do you bring ethics to bear on the commercial drivers behind AI and the potential exploitation in that area?
And I saw, yes, please.
Yeah, please. It's a question about genome editing. There is plenty of other area where genome editing is very important for human health, and I'm thinking to antimicrobial resistance, vector control, nutrition. So I just would like to know if the committee will just focus on human genome editing or may one day expand to other areas which are very important for health. Thank you.
So we just heard there the expansion of human genome editing. We also had about apps talking to one another. So there's a more holistic approach to all of this. What would you do with your dollar? What's the potential in terms of enabling infrastructures and utilization of digital health, and also WHO as providing that stewardship for equitable access, and also potential gains and ethics to be positioned with the commercial drivers? Dr. Swaminathan, I know that we can't answer 5 questions, but if you could just capture in essence some of the ideas being expressed here.
I just want to thank everyone for their suggestions and comments. I think really important points have been raised. And what we will do is, as you know, we're developing the digital health strategy now. It's been out for public consultation. We've had a lot of comments, about 200 comments received. We're revising it. It's going to go to regional committees. there'll be opportunities further to shape it. But I think many of these points have come through in the comments that we received. And it's really going to be important, I think, to be clear about what member states can do and should do. And I think the point that Mary Paul raised was it's really important for countries to have a strategy that looks holistically at the overall system and not do piecemeal work. And so a national e-health or a national digital health strategy is really going to be important for countries to develop. And WHO needs to really outline what the elements of that need to be. And this will include, I think, things like interoperability and where there's an evidence base before you launch it. But also, again, I think the issue of ethics around some of these technologies. Specifically to your question, Florence, I think it's true that we need to consider many things beyond human genome editing. The same committee will not be able to address everything. And so we are thinking about having other ways of doing that. We should think about what emerging technologies perhaps could be considered together by another expert advisory group. But I think more important is developing the frameworks so that also national authorities and regulatory agencies, as well as national research councils, could look at some of these and consider how to make national rules and regulations. So I'd just like to thank all the panelists for really making wonderful, brief, but really very informative presentations, and to the audience for staying through. Thanks, and to you, James, for moderating it so well.
Thank you. We just want to add that your ideas and questions and solutions are always welcome. Dr. Vasimurthy, who has helped design today's session with Dr. Swaminathan, is your focal point for this. There's also a live stream behind you, actually. It's been live streamed, and I don't have the exact address for you, but if you just go to the WHO social media account on Twitter, you'll be able to find it just by scrolling down to about the time it started at 8 a.m. today. And we have the next technical briefing at 12:30 on universal health coverage. Thank you to everybody for being here, and thank you to you.